Hi, everybody, and welcome back to another episode of The Black Unicorn. I have a really interesting guest here today. His name is Chris Lowe. I'm very excited to talk about some issues going around the healthcare topic that's been floating around since Trumpcare, as I like to call it, didn't pass. And Chris, you have a lot of insight on this issue. You've done a lot of work in the past around healthcare since long before this, haven't you?
Yeah, that's right. I live out in Portland, Oregon, and I've been a healthcare activist, reform activist for about 10 years in Portland. Um,
Nice.
I am an advocate for you'll often hear the term single payer. It's the same thing as when Bernie Sanders says Medicare for all,
Okay.
universal public health insurance, basically. and
Mm-hmm.
um, I actually first became aware of this idea back in 1990. There was a guy named Harris Wofford who won a Senate race in Pennsylvania running on this platform. There was a group of doctors who had put this idea forward, and you sometimes will hear references to Hillary Clinton having worked on healthcare
Mm-hmm.
reform in early 90s when Bill Clinton was president,
Okay.
and there was interest even then. The healthcare system in the United States.
Is she was sorry, I'm sorry. I just want to understand. She was working on she was interested in single payer healthcare or just in reforms in
Well,
general.
she proposed something a lot more complicated that was sort of trying to compromise with the single payer idea, because single
Okay.
payer, to get to it, it basically means doing away with private health insurance. So the private health insurance industry obviously doesn't like that. So,
Well, not
right.
like that, no.
So, so, so she was trying to find ways to sort of, square the circle there and keep them involved somehow. Um,
Huh.
and,
Okay.
and, and the ideas that became the Affordable Care Act actually came out of that period as well. They were, at that time, the Republican conservative counter to what Hillary Clinton's, the Clinton ideas. And so there's certain ironies about today's politics, because basically the conservatives have been refusing to take yes for an answer. The Democrats moved over
Mm-hmm.
and adopted their ideas. But anyway, so
Mm-hmm.
I was paying attention to it back then, and in the late 90s, I worked in the efforts to build a labor party in the United States. I'm a democratic socialist and have been for 30 years.
Nice.
And this is an idea, the single payer idea of universal health insurance is a democratic socialist or social democratic kind of idea. It's similar
Right.
to what they have in Canada, or Taiwan are the closest to what we're proposing. But you know, um,
Okay.
it's in a certain sense it's socialized insurance. It's social insurance like Medicare or like Social Security. It's not socialized medicine like they have in Scandinavia or the UK, where the docs and the nurses and all the practitioners are employed by the government. What we're saying is
Very
the
interesting.
public
Okay.
should handle the financing, but the delivery of care is still the whole diversity of care delivery.
That's a very interesting idea. That would assuage a lot of concerns. You hear conservative people saying that they get scared that government control over the doctors means what kind of care will be allowed to be given to people, that it'll limit people's choices in a lot of ways. And that's interesting. So that would basically mean that there would still be that sort of freedom that they're looking for on that end.
Yeah, and you'll find that actually the doctors are pretty divided. That pretty strong majority of primary care physicians support the single payer approach, partly because they are
Okay.
underpaid in the current system, and then docs who do very expensive specialized care tend to be less supportive. Although a lot of the docs I know who are activists in the movement, are actually anesthesiologists or oncologists or people who you know but part of the idea about the single payer is to simplify the administration, and there are a lot of doctors who feel like the current insurance system gets between them and their patients, that they have to spend a lot of
Hmm.
time administering, making claims, following up if a claim gets denied. They have dozens of different health plans they have to deal with, and the way the compensation works, it creates incentives for really short kinds of appointments and not being able to have relationships with their patients. So the docs who
Mm-hmm.
are and nurse practitioners and anybody else who's in that kind of billing situation, um, who support this idea, what they want is to focus on treating people. Uh,
So you're saying that by simplifying the billing process, that will free up the doctor's time to actually be a
right,
doctor.
and exactly,
Right.
and it will also mean that there's about 30% of health dollars that are spent in the United States goes to administering insurance in one form or another. So that's a huge amount of money that's not actually going to care. So the other point
Mm-hmm.
about the administrative simplification is it would allow much more effective use of the financial resources to go directly to care. Um, so traditional Medicare has about 2% administrative costs. The Medicare Advantage, which involves some of the private insurance companies offering plans within Medicare, is about 7%. So there's this large extra increment that's going to profits, that's going to back and forth between the providers and the insurance companies, that's going to employers having to deal with multiple plans. You know.
Right. Right. So I have a question. Well, to be honest, I had actually never even heard of. Well, actually no, that's not true. I have heard of single payer healthcare, but I totally glossed over it until this whole issue came up with the Affordable Care Act and now Trumpcare. Um, I'd actually like to understand more about the Affordable Care Act, why people like it, why people hate it, and I actually would like to hear more about. I think it's interesting. You said that it was actually a Republican plan that they sort of revamped,
That's right.
correct?
Um, so,
Okay.
okay, well, just on the term single payer, that's about the administrative costs, and it's a very opaque term. It's hard to understand. So, in we'll come back around to this, but I just want to put the term universal risk pool out there as another analytical way of understanding what's going on, that we're
Mhm.
sharing insurance risks. So with the Affordable Care Act, the piece that's the most comes from the Republicans is this idea of exchanges, where people who don't have insurance through their employers have a well organized marketplace where they can identify different plans that might suit their needs. And then the insurance companies offer plans that are supposed to compete with one another, and competition is supposed to lower the prices. So that's one piece. And but if you look at the overall architecture of the Affordable Care Act, it's a relatively small piece. It's about 7% of people in the United States are in that individual or small business market. About half are
Okay.
in employer-based insurance, and about 15%
Right.
each in Medicare and Medicaid, and then there's some other pieces. But so in the Affordable Care Act, there are some regulatory features that cover all insurance. They cover employer-based insurance as well. So the banning of excluding people for pre-existing conditions,
Right.
caps on lifetime, banning of lifetime benefit caps, banning of annual benefit cap.
I'm sorry. What is that?
Um, a lot of old insurance used to have a cap on how much they would pay out over the course of a lifetime. So it might be $1 million cap or something, which sounds like a lot of money. But if you've got
Oh,
certain kinds of very expensive cancer, or
issues.
get hit by a
Right.
bus and have crazy osteopathic issues.
Chronic
So
issues.
so that kind of cap. Some of the plans used to have annual caps that went away. There was, gender discrimination. Women were charged more than men. There was a wide
Huh.
range of
Don't women live longer than men? Usually, isn't that the
right, and exactly.
right?
So that's the actuarial claim. But but the question is, what do we want insurance for? Is insurance meant to keep
Right.
us healthy, or is it about actuarial equivalency? And I'm for the former personally. So anyway, there were these, what I consider kind of abusive private insurance practices that were banned, and
Mm-hmm.
then there were also regulations that required all insurance to cover a set of essential benefits. There are 10 of them. They range from things like, hospital and operative care to mental health to reproductive health to, so a number of different things. And also there was a requirement that 80% of premiums go to care. And basically both of these things, putting a floor under how little benefit can go in and a floor under how little money out of the premium can be paid, I consider sort of limits on lemon insurance. And then they also, the last sort of regulation like this was it imposed an annual out-of-pocket maximum, which I think was about, it's like $6,000 a year for an individual and $12,000 for a family. So in terms of like if you're paying deductibles and co-insurance and co-pays and all of those things, what you pay out of pocket and your premiums themselves, all of that can't add up to more than $6,000 for an individual or $12,000 for a family.
Interesting.
Um,
So, uh
well,
huh.
just go ahead.
So,
Yeah, that's fine.
okay. So this is what the Affordable Care Act has done for us.
On the regulation
Um,
side, the
on the
the
regulations.
other
Okay.
side of it
Uh huh.
was it was trying to address a problem of a lot of people being uninsured. So by the time that they were passing the insurance, by 2009, 2010, it had gotten up to about 50 million people, which was about a sixth of the entire population of the country at the time, had no insurance at all. And then other people had some kind of insurance, but often couldn't afford to use it. So,
Right.
but ending the uninsurance was particularly important. So there's an individual mandate that says you have to be insured. It turned out that the Republican idea of just having people buy in the exchange only works for people who have enough money to buy in the exchange. So there was a big expansion of Medicaid, which is Medicare
Mm-hmm.
is the seniors and disability program. Medicaid is the low
Mm-hmm.
income program. And
Right.
Medicare is national, where Medicaid is state by state. The feds pay about half, and the states pay about half, and the states can shape it more. So anyway, before the ACA, Medicaid, you had to be at 100% of federal poverty level or below for income, and even at that, it was often inadequately funded in the states. So, like in
Right.
Oregon, only 10% of adults who were technically eligible could get Medicaid because there was a, what do you call, a lottery to get into it.
A lottery
Right.
to get get
Right.
Medicaid.
So
Huh.
all the kids were covered, but if you were an adult and you wanted, you took your chances. So
Wow.
the what the ACA did was raise the level to 138% of federal poverty level, and that expansion, and it was fully funded up to that level for everybody who fell under that level would get on it, and it was funded mostly by the feds. So it was a big incentive to the states. And then there were these individual and small business plans in the exchanges for people who were between 138% of federal poverty level and 400%, which like 400% of federal poverty level for a family of four in that period was something like $80,000. So it was getting far up the income scale where you would get some kind of tax credit for buying in the exchange.
And so what?
Well,
Uh huh.
just the Medicaid
Um,
expansion, unfortunately, the Supreme Court ruled that the feds couldn't make the states take it, so 19 states didn't. So it didn't. There are a bunch of low wage workers who remain uncovered who could be if the states took it up. But,
so this lottery system still exists
well,
in some
that was what
places.
Oregon did. I don't know how other states handle it. So
Oh, okay. So, what are some of the reasons that people almost rage against ACA and say that there was this horrible thing that happened, and that a lot of people complain about having to pay the fines and everything. I don't even. I'm not really sure exactly when those fines are even applied, or how much people are really paying, or if there are any other issues that people had. What made this push for Trumpcare to even happen?
all right. Well, my understanding of that is that it has to do. It's primary when people talk about Obamacare, they mean mainly the individual market piece of it. So if you actually ask people, well, do you want, ban on pre-existing conditions to go away? They say, no, we want to keep that. And in fact, Trump Care didn't repeal that. So, and the other thing that happened was President Obama, when he was selling the program, said, if you like your insurance, you can keep it. And of course, that wasn't true before either, because if you liked your insurance, you could keep it if the insurance company kept
If they let
offering
you.
that version. If your employer
Right.
kept offering it to you, you know,
Mhm.
I once lost a doctor because my employer shifted the plans that they included in the ones we could choose. So it wasn't true before, but after the ACA passed, certain plans that had existed stopped existing because partly because in many cases they were what I would call lemon insurance and they didn't cover a lot, so they had to meet these new standards. But people who
Mhm.
thought they had a plan of how they would handle situations using those plans, they got pissed off about losing those. um,
Hmm.
and so and then premiums continued to go up. And again, there's a sort of false implication in the opposition that that wasn't happening before. In fact, part of the reason for the Affordable Care Act was that premiums and coinsurance were rising very rapidly, and in fact they were rising more rapidly before the ACA than under the ACA. But this is the
Mhm.
image. And then the other thing was the media, because the Tea Party was very effective in organizing its opposition in 2010, the media went out and got all the anecdotal stories of people who were unhappy for those reasons and didn't collect the anecdotal stories about people who
Mhm.
had pre-existing conditions who could now get insurance,
Right.
or people whose insurance
Right.
went down because they were women and they were being discriminated against, or went down because they were old people and they were being
Right.
discriminated against, or who really benefited from the income-based tax credits. So some of it's just a question that the narrative focused on the pieces that people hated the most, in fact.
Mhm.
But on the other hand, there were really, were problems with, and are problems with the ACA. It's still, I said 50 million people were uninsured before. Well, about 20 million people or
Right.
so gained coverage, which is, and in many cases, real access. Coverage doesn't always mean access, but, real. So that was, a big advance, but there's still 30 million people in the country who are uninsured. Uh, the,
Right.
the biggest thing, though, is that competing over the price of insurance actually can't control rising costs. So this is, the Republicans like to talk about competition is the answer, but it's really not in healthcare, and it's even less so when it's health insurance,
Hmm.
because the health insurance prices are driven by the underlying cost of the care itself. So what the providers,
Right.
the hospital systems and the docs and the nurse practitioners and the naturopaths, what they bill the insurance companies is what leads to their price setting. So, there's only so much they can do competing with one another, except by tactics of reducing their costs. So how do they do that? They either
Right.
push people out, so you push out the riskiest people. That's the pre-existing conditions thing was about that. But there are other ways to do it. It's called
Right.
adverse selection. You try to select the least risky people if you're an insurance company, and you try to push out the riskier people, and that's how they compete. It's not about
Right, and that's
right,
not it's not right. It's not the same thing as when you have a product on the market like a toy or an electronic piece. It's not a supply and
right.
demand issue. It's not how many people want to buy the new gadget. It's about that there are these needs that have to be met, and it's not you can't it doesn't yeah, it doesn't
Right.
work the same way. It's that's
Right.
very,
And then
very
it also
interesting. Right.
turns out that in terms of sort of actual care, if you think about it, why do we go to a doctor? Well, it's because they know things we don't know. So we're actually not in a great position as actors in a market for medical services to judge what we need. Where it's not just us; it's us plus our doc, it's us plus our
Right.
calculation of how much we need it now versus can we wait 6 years to do this or whatever because we have to pay the rent or we got to pay the kids college or whatever the thing is. Um, and it turns out people are really pretty bad at discounting, as the economists say, the future healthcare needs and costs. Anyway, so that's basically the things that were driving up the costs and that were pushing people out of insurance, making it unaffordable, haven't changed. And Obamacare, the ACA couldn't really change them. What it could change to some degree was who was covered and some quality features of the coverage. So, there were real gains for people who got into the system or who were already in it, but it was very partial. So the people who, like me, who were supporting single payer, supporting universal risk pool, supporting Medicare for all, everybody in, nobody out, that's what we wanted back then, and it's still what we want because the ACA only got us so far. So what? So should we
Right.
turn over to Trumpcare then? Do you think, or
Yeah, I'd like to talk about that. What they thought they were going to get out of it. What the people who wrote the bill thought they were going to get out of it, and what the impression was. Because I think that it might not be the same thing. What the people supported it
right?
for, and why it didn't go through.
Well, I think that there are several aspects of this. So I think the people who opposed it, there was a there were some of them who really felt like they had lost something under the ACA. Who were in the individual markets and had liked some thing that they had that went away or became much more expensive. So, and then there was a whole other piece of it that was a kind of partisan thing where it was seen as not enough competition, too much government regulation, and there were people, out in the public who got behind it because it was just, the Republican demand for the last 8 years was repeal and replace Obamacare. What it would have done, and then there was this other kind of bait and switch agenda going on, where if you look at
Right.
Trump's overall program, he wants to cut taxes for the wealthy, and to some extent for the
Right.
rest of us, but mostly for the wealthy, and and but
Right.
he also needs to pay for that somehow within the budgeting process. So the way he wanted to pay for it was by cutting spending on the ACA. So it's basically a transfer of wealth from benefits to ordinary people under the ACA to tax cuts for the wealthy. So that was another big piece of the
Right.
agenda. So the way it was going to work was on the Medicaid expansion, they were going to convert Medicaid to what are called block grants, which are, instead of being based on individuals who join the program and the states spend a certain amount and the feds contribute an amount, the feds would give a certain amount of money for Medicaid to the states, which would tend to stay the same even if more people were coming on. After 2020, new people, it would go back to 100% of federal poverty level. So the expansion would be sort of gradually rolled back. They were going to repeal the individual
Right.
mandate, which a lot of people, felt was,
That's what people
or
were
yeah,
complaining about.
they were going to change the tax credits and cut them, but they were going to change them instead of being based on your income, they would be based on your age. So this was going to mean
That doesn't make sense to me. Yeah, I'd like for you to explain that because I don't. Right.
basically it's saying, the older people get, the riskier they become from a health insurance point of view. So it's basically saying,
Right.
older people, you're the ones who are creating the costs in the system, and so you have to pay more, and we think you can do that because you've lived longer and you're going to have higher incomes than younger people. And there's some very
Uh,
general truth to that, but income, they're older working class people who've worked hard all their lives and still make less than median income, and so it's just
right.
it's
Yep.
not, there's just different kinds of jobs in our economy and they pay differently, and so it's just and so it's a viewpoint that comes from the economically privileged segment of society that sort of ignores
Right.
that kind of inequality. Um, and then they were also going to repeal some of the regulations that against what I would call abusive insurance practices. They were going to allow more age discrimination in the plans themselves. They were going to
I bet
allow life.
for women,
No, actually,
sorry,
I
the
don't think that they
uh-huh.
were going to repeal the gender equality piece. I think they realized that that would just cause a huge uproar. So
Hmm.
because it's just it's although you do see that in terms of the arguments that were being put forward, you know Charles Krauthammer and other whiny Republican pundits say, why should I pay for women giving birth? Well, come on, Jesus, it's just you know
Oh my goodness. Oh, I no, wasn't it
prenatal care,
prenatal
right,
care?
oh,
Wasn't it, or like
right,
prenatal vitamins?
right,
Oh my goodness, that really boiled my blood. Oh, why take care of the child
right,
after it's born even?
right,
Why why
right,
support
right.
your wife?
No,
Why
and
it's just so
right,
it's so bizarre. Why feed
right,
it?
so it's but and it's kind of like so what are we going to do? We're also going to make separate plans so that men can buy plans that don't pay for women's healthcare needs, and women can buy plans that don't care for prostate cancer and Viagra and all the other whatever.
Right.
So it's just you know it's a different kind of moral thinking than what insurance is really about, if you, in the proper sense.
Right.
But anyway, so they were going to allow some of these. They were going to restore lifetime maximums. They were going to allow plans to have less spent on actual care, which means more profits for the insurance
Right.
companies.
Just so it sounds like overall, it's just less
Right. So
coverage.
yes, yeah,
That's
that
what it
was the
sounds like.
practical effect of it.
Right.
The Congressional Budget Office estimated that by 2026 there would be 24 million more uninsured people than if the ACA continued to that point as a result of Trumpcare. So it'd be a huge re-expansion of the uninsured population, and all of their costs end up coming back into the insurance prices for the insured people, because we haven't quite reached the point in society where we say just die in the streets. If you can get to an ER, you have to get treatment. Of course, it's
Right.
the least effective, latest stage treatment that costs the most. So it's a really stupid way to provide universality, to have ER emergency department universality. It's really stupid. Um, but that's what they wanted to do. And basically the way I look at it is what they were offering to the public was you can have a chance to buy less expensive lemon insurance. It's like, okay, well,
That's what I love the most is the insurance that you pay for that doesn't cover you once you've paid for it and you need it. That's just that blows my mind that it even can
Right.
exist legally.
And similarly, with the repeal of the individual mandate, you can have the privilege of being uninsured. You know, yay! You know?
Great.
um,
I know it's a
right.
strange thing. I don't understand why um ideas like these get any support. I don't understand it. I get the idea. I see, some people feel that they don't want to have to pay for other people's expenses. That some people feel that way, but the thing is like I feel like it. I want people to have health care. Now, there are things like, it's unfortunate if somebody gets cancer and they're hardworking and they have a family, but they just can't cover those costs. That's a shame. But also, I feel like it's also a matter of public health. I imagine that if everybody has health care, then as a society, we're just healthier. It's better for the overall, the quality of life in the place that you live. Like, you wouldn't want to live somewhere where everybody's getting chronically sick with preventable
Right.
issues.
Yeah.
you know?
It's in the Constitution. It's in the preamble. We say promote the general welfare, which means well-being of the people.
Huh.
That's part of the purpose of our society, according to our Constitution. So, you know,
Very
I look
nice.
at this as a
Right.
preamble issue, um, but it also, in terms of people paying for other people, what that reflects is that people don't understand how insurance works, right? So, and this is what brings us around
Mm,
to the idea of universal risk pool, because insurance
right.
is based on, we get a bunch of people together who all know that they are at some risk of getting sick or injured, and but they
Right.
don't know when that's going to happen. And they do also know that when it happens, it's likely to be really expensive and put a spike in their expenses that doesn't match. Their income won't spike. And in fact, it'll probably go down if they get ill or injured, or could go down. So you create this thing called insurance, where a bunch of people go in and share the risks over, however long they're in whatever the plan is. Um, and
Mm-hmm.
and some of those people do get sick or injured during that period of time, and some of them don't. So when I'm paying
Mm-hmm.
a premium for I happen to buy my insurance in the exchange right now, and when I pay for my premium, I'm partly paying for what I use, but actually, my deductible's high enough that a lot of it, I've been paying out of pocket, but I'm also paying for other people who are in the Kaiser system, or in my particular plan probably, who are having much more expensive care, and my premium pays for their care, and their premiums pay for if I get hit by a bus next week, or
Right.
turns out that I've got some disease that I don't know that chronic condition that I know I don't know that I have now.
Right.
So we're already paying for one another within the private insurance market.
Right.
And, the big idea for me behind Medicare for all, improved Medicare for all, is a universal risk pool. So what we're saying is the whole population, and the time period is from prenatal to death, all of that risk
Mm-hmm.
is shared. And we're doing that. And if you think about the insurance principle, how that's going to work out, that's actually going to end up being economically the most efficient, because you're not spending time and money trying to analyze who's riskier and who's not, and cut people out, and you're not spending time trying to avoid paying for necessary services. There are all these expenses that are caused by the competition to get the less riskier pool when you fragment the insurance system. So a universal system is economically
Mm-hmm.
more efficient, and it's also more health
Mm-hmm.
effective because you say everybody is covered for, comprehensive benefits. So when you have a need, you can go and meet it right away. You don't have to calculate whether I can afford it or not because the funding has been come up
There.
front. So you're not deferring care,
Right.
and that means that if you've got something that's wrong, generally speaking, the sooner you can get care for it, the quicker it's going to
The
heal,
better.
the less likelihood of it developing
Right.
into something worse. All of which also becomes more
Right.
expensive. So again, it's more economically efficient, and you can also use
Right.
the buying leverage of the single payer is also, from the point of view of service providers, it's a single buyer as well. So you can use that leverage to reward health systems that do health promotion and prevention. So, a lot of ill health
Right.
comes from health behavior, right? So if I don't walk
Right. Right.
every week, every day, or do something, my health's going to get worse. Health systems can encourage people, help, some people are really good at doing that stuff individually, but a lot of us, it helps if somebody we can talk to encourage us, we're part of a group.
If it's community,
Right.
yeah, community. When you're entrenched in a community of people who are supportive towards that type of healthy lifestyle, it absolutely is
Yeah.
exponential in
Right.
helping people to actually get that done.
Right. So Portland's got a real strong bike community, and there's various things they like about biking, but the health is certainly a piece of it. My former
Hmm.
mother-in-law lived in a little rural town in eastern Washington, and there was a group of 8 or 10 farmers and local business people who would go out walking every morning, and they did it as a community thing, and they would
Hmm.
talk about whatever the news in the town was, or on the TV or whatever. And
Yeah, it's a beautiful idea, a culture of, us deciding to live healthy lives together as a society and economically encouraging that. It's a really
right.
beautiful, powerful idea. It is.
So the universal publicly funded insurance is at that scale of the way that we constitute ourselves as a community oriented to supporting one another's health.
Right.
And that's really, to me, that's been my real motivation about it, for as long as what was causing the problems. Just take brief notice of it. American health, we pay nearly twice as much as any other country in the world by several different measures, whether it's as a proportion of our total GDP or GDP per capita or annual spending, any
Mm.
other country in the world, and we have much worse outcomes, what measured by many measures, life expectancy, maternal deaths in childbirth, all kinds of statistics.
Wow.
So we're paying more and getting less, and a sixth of us are not getting anything, and it doesn't have to be that way. So
At all. Right.
and there's mortality, and their calculations have been done that something like 40,000 premature excess deaths per year due to lack of insurance. But the public health people talk about morbidity as well, which is ill health, right? So pain,
Hmm.
suffering, permanent loss of function, just decline of the physical aspects of the quality of life. And to me, it's that and the worry, the financial worry about going bankrupt from medical bills, and the worry about the health of relatives and friends who have some kind of condition or having trouble paying for it, not getting the care, putting off the care they need, and they should go and see the doc, but how can they do that? There's so much extra burden that we
Right.
put on ourselves. That make us less happy.
Right. Absolutely. Well, I have a question. So, since you've been working as an activist in this area as long as you have, I mean, the idea, I love the term that you brought up, universal risk pool. I think it's a great term because it sort of helps you to envision what it really is a little bit better than the single payer term.
Right.
I love everything that we've been talking about, building this idea that we can actually bring health and actual care to society. These are beautiful ideas.
Right.
But how do we get there from where we are? What is your idea? Like, what do we do if we want this? How do you envision this coming into fruition?
Well, the first thing we have to do is, pay for it.
Uh-huh.
Because there's so much waste in the current system, we can pay for it. But a piece of the efficiency of it is that the payment becomes less fragmented. So right now, we're paying some in our taxes for various public programs, and which we may or may not personally benefit from. And we're paying, if we have insurance that we're buying, part of our premium goes to cover uncompensated care and tax benefits that employers are getting that mean that they're not putting revenue in that may mean our taxes are, so we're paying in these different ways, but a lot of them are not that visible. And with a single payer system, what will happen is it will become more visible, which from the positive side is more transparent. You'll know what your national health insurance premium is because it'll be in your tax bill and you'll be able to predict it, and it'll be pretty similar from year to year, and which isn't the same as with the premiums and the deductibles and so on with the private insurance. But it may look big. And the other thing is, we pay premiums and then we pay out of pocket before the insurance kicks in. So the comparison, over 10 years, it'll clearly, for almost everybody, be less to be paying into a single payer system. But in any given year, it might not be. So there's a persuasion problem around that. But the mechanism, the one I most favor is there's a bill in Congress. It's called H.R. 676, Improved and Expanded Medicare for All. John Conyers, who's a representative from Michigan, has sponsored this for about 12 years now. And that's the gold standard as far as I'm concerned.
Okay.
Bernie Sanders is going to propose something related but different in the Senate. There are also state single-payer movements in a lot of states and people exploring doing it at the state level. It's a complicated process, and we're doing that in Oregon. We hope maybe to have the legislature refer a plan in 2020, but we have to build up enough of education and a base so we could win on the ballot if they did that. What we really hope is that if a few states did it, that it would make the national debate, make it appear more realistic.
Right.
But one of the things that happened in the
Absolutely.
last 3 months, or since President Trump was elected, is that the Republicans chose to reopen the debate, and they've put healthcare back on the table. So now we're in a position where Bernie Sanders was raising up the universal healthcare idea, and they've opened up the window. So
Right. They made it relevant again. They surely did.
One of the things the movement is doing now is trying to get people to ask their representatives to co-sponsor H.R. 676. And we've had 3 representatives in Oregon who've done that in the past, since January.
Okay.
But we got to build the movement. We got to build the education to
That's very good.
understand
Okay.
what it is. And
Right. Yeah, and this, I hope, will help to do that. I really like the idea of getting these ideas out there and getting these ideas into people's heads and what they can do to actually make some of these changes happen.
Right.
If people can see it
right.
and understand it, then it becomes more feasible to. That's the only way that you can really manifest anything,
Right.
is with that understanding and that vision. So.
And Sanders is putting forward a couple of ideas that I support that can also be more possible in a slightly shorter run. So
Okay.
the one that's most possible probably would be really creating the capacity for negotiation over drug prices that is pretty much barred for Social Security and for a number of other kinds of entities.
Okay.
So that one, I think you could even get Republicans behind that. So you might be able to put together
Okay.
a coalition in Congress to pass that in a relatively near term. Another thing he's proposing is to lower the age of Medicare eligibility. And I don't think that's going to happen as long as Trump is president and the Republicans control Congress. But it may be easier for some people to imagine. So Medicare would start at 55 rather than 65. And you'd have to figure out the funding mechanism for that.
Right.
But it would tend to stabilize the current Medicare system because that 55 to 65 group, while it's riskier than younger people than that, is less risky than the 65 plus crowd. So you're creating a broader risk pool. And you could use it to talk about what does it mean to be, sharing the healthcare risk. You could use the argument for it that to move towards, full Medicare for all. So, that's worth talking about. I have some single payer movement friends who feel like, well, no, it's also it's still helping the private insurers out because now they don't have to worry about paying for older chunk. They can focus on the younger people, and
Okay.
so there'll be debate about it,
Right.
but it's at least worth talking about.
Okay. Well, I think this is a lot of information. This was really great. I really appreciate you sharing all of this information and talking today.
Well, I'm really grateful for the chance to do it. It's taken up a lot of my life for 10 years, and I'd really like to, it's
Yeah,
great to have a chance to get the ideas out there more.
it's good because it shows that all the work that you've put in this shows that your opinion has weight, has value. So that's really great. Maybe in the future maybe we can have another episode. You can give some updates if anything changes, if there's any progress on these issues. It would be really great to let people know about it.
Sure.
That would be really exciting, actually.
Right.
I just want to thank everybody that's also listening for taking the time to come in and listen to these issues and take interest in something that affects us all. And hopefully we all leave a little bit more informed and optimistic, and we know a little bit better what we could do to actually make the change that we want to see. So thank you, everybody, for joining us at the Black Unicorn, and I look forward to being with all of you again. Thanks.